Welcome. It's time for the YouTube. Peace. Welcome, YouTube. It's time for the live book reading of Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. I'm your moderator and narrator, Uriel Riley. Hi, it's Heart Love and welcome. Peace, YouTube. Pick up in the 30th chapter. Peace, everyone. Welcome. Here we go. This would be episode 75 of this book reading. Hi, it's Heart Love. I'm your moderator and narrator, Uriel Riley. Thank you so much for being here and reading with us. All the book lovers community, all our friends and family, all in the replays and playlist of this book. Wish that you enjoy the reading. All right. We pick up in the page 451 in the middle. Here we go. The 3 clinical goals of PEEP. 1. To assure tissue oxygenation. This demands maintaining an adequate cardiac output. Any increase in arterial oxygen content accomplished at the expense of cardiac output is potentially detrimental to the organism. 2. To accomplish adequate arterial oxygenation at FiO2s, not detrimental to the lung, arterial PO2s above 60 millimeters Hg represent more than 90% oxyhemoglobin saturation. With adequate hemoglobin content, this level assures adequate arterial oxygenation. When this can be accomplished at 40% or less inspired oxygen concentration, the oxygen therapy should not be detrimental to the lung. Healing. 3. To optimize lung compliance, this will allow spontaneous ventilation, CPAP, or IMV over IDV, with minimal work of breathing. If PPV augmented or control is necessary, lung pressures will be minimized. Theoretically, all 3 goals are simultaneously accomplished by reestablishing a near normal FRC and maintaining a proper vascular volume to vascular space relationship. PEEP therapy without pulmonary artery catheter. 2 preconditions must be met. 1. The diagnosis of ARDS must be reasonably certain. And 2. The cardiovascular system must be clinically judged stable and capable of meeting the metabolic demands of the untreated disease state without threat of decompensation. The following case studies are presented to clarify general principles of acute respiratory care. They are presentations, nor are they to be interpreted to comprise the entire care required by these patients. All right, this is the section. Peace. Hi, it's Heart Love, David. Hi, it's Heart Love. Yes, we're reading Clinical Application of Respiratory Care. We're in the 30th chapter. We just turned over to page 452. We're dealing with adult respiratory distress syndrome, which is ARDS, right? And now we've reached the part of this book. This is a pinnacle where we're going to go through case studies. All right. So for all those taking notes, I'm going to run through them and we'll complete the chapter. So, hi, it's Heart Love. Thank you so much for being here with us. Peace, Jay. All right. Case CPAP. A 25-year-old, previously healthy man was hospitalized for a severe viral pneumonitis and remained stable with oxygen therapy, FiO2 0.40. On his third hospital day, he became increasingly dyspneic, tachypneic, and revealed a refractory hypoxemia to 100%. Interpretation changed from resolving interstitial pneumonitis to a typical ARDS pattern. Upon transfer to ICU, he was noted to be very short of breath, using all accessory muscles and unable to speak more than 3 words at a time. BP 140/100, pH 0.46, P 130, PCO2 29, RR 40 and regular, PO2 41, VT 600, FiO2 0.60, MV 24. After careful of the proposed therapy, the patient's nose was appropriately anesthetized, and he was intubated via the nasotracheal route. He was placed on a CPAP system with 5 centimeters H2O PEEP and 60% inspired oxygen. 15 minutes following intubation. Blood pressure 140/100. Sorry, BP 44, P 231, RR 30, PO2 45, VT 600, FiO2 0.60, MV 21.6. PEEP was increased to 10 centimeters H2O 5 minutes later. BP 140/100, pH 7.44, P 120, PCO2 30, RR 36, PO2 43, VT 600, FiO2 0.60, MV 21.6. PEEP was increased to 15 centimeters H2O 10 minutes later. BP 120. 7.42, P 110, PCO2 32, R 28, PO2 58, VT 500, FiO2 0.60, MV 14. It's during which vital signs, clinically condition, and blood gases remained unchanged. PEEP was then increased to 20 centimeters H2O 10 minutes later. BP 125/85, pH 7.37, P 110, PCO2 35, RR 22, PO2 110, VT 500, FiO2 0.60, MV 11. The patient's breathing was significantly less labored, and he communicated that he felt very much improved. 15 minutes later, on 20 centimeters H2O PEEP, BP 120/75, pH 7.35, P 100, PCO2 38, RR 22, PO2 180, VT 450, FiO2 0.60, MV 9.9. The FiO2 was decreased to 0.50. 10 minutes later, vital signs were unchanged. pH 7.36, PCO2 38, PO2 110, FiO2 0.50. The FiO2 was decreased to zero point 0.40. 20 minutes later, vital signs were unchanged. pH 7.36, PCO2 37, PO2 73. Wow. And FiO2 0.40. Note that within 2 hours of initiation of PEEP therapy, the clinical goals were reached, namely 1. Circulatory and perfusion status remained adequate and stable. 2. Adequate arterial oxygenation at FiO2 0.40. 3. Work of breathing significantly diminished. Patient comfortable and breathing without significant effort. A total of 350 milliliters of crystalloid solution was administered intravenously during the 2-hour period, which needed to be noted. And just for also those taking notes, here we go. BP equals millimeters Hg, and P equals per minute, and RR equals per minute. VT equals milliliters or ml, and MV equals liters over minute. PCO2 equals millimeters HGP, and PO2 equals millimeters Hg. Yeah, and same on the other side. Okay. Case study CPPV. A 34-year-old woman was getting out of her parked car when she was hit by a passing auto and suffered multiple fractures of both legs. And pelvis. She was placed in traction and received 3 units of blood. For 36 hours, she was stable and then suddenly complained of severe shortness of breath. She was noted to be tachypneic, and tachycardiac, mildly hypotensive, and intermittently obtunded and agitated. The urine was positive for fat content. Respirations were labored. Urine output was adequate, and extremities were warm and dry. BP 100/60, pH 7.41, P 110, PCO2 33, RR 36, PO2 35, VT 30, FiO2 60, MV 10.8. 100% inspired oxygen increased arterial PO2 to 42 millimeters Hg. The patient was intubated following ventilation by bag and mask and sedation. Spontaneous respiratory efforts were minimal, and she was placed on a volume ventilator with 5 centimeters H2O PEEP and given 300 milliliters IV fluid. BP 100/60. Whew. We can do it. We have the ability. We already did it, right? Hi, it's Heart, Love, Peace, everyone. Hey, Gigi, what's going on? Oh, my goodness. Peace, we're reading medical books, and you would know about this. Let me make you a mod. Oh, my goodness. Hi, it's Heart, Love. One of my original mods. I hope you get that love. So much love. Reading clinical application of respiratory care. We're in the 30th chapter and almost complete another book on this YouTube channel. You know, you always tell me to keep going, and that's what I do. Keep going. Wow, it's so great to see you here. I hope you get that love. Peace. All right. RR0, VT0, MV0, ETV 900, rate 8, MV 7.2, PEI 40, PEEP 5, ESC 26, pH 7.43, PCO2 32, PO2 38, FiO2 60. PEEP was increased to 10 centimeters H2O and 100 milliliters IV fluid administered. 15 minutes later, BP 110 over 70, P 120, RR 0, VT 0, MV 0, ETV 900, rate 8, MV 7.2, PEI 45, PEEP 10, ESC 26, pH 7.42, PCO2 33, PO2 41, FiO2 60.60. PEEP was increased to 15 centimeters H2O 10 minutes later. BP 110 over 70, P 120, RR 20, VT 100, and MV 2. You see the big increase. GG, I hope you got that love. You definitely are one of the original mods on this page. Highest heart love. We're going through the case studies. All right. You see that all increased. That went from zero, all zeros the first two times, and now RR 20, VT 100, MV 2, ETV 900, rate 8, MV 7.2, PEI 45, PEEP 15, ESC 30, pH 7.42, PCO2 33, PO2 55, another increase. FiO2 0.60. Note that spontaneous respirations have returned. Likewise, ESC. Yep. And down here at the bottom, BP equals millimeters Hg. P equals per minute. RR equals per minute. VT equals milliliters. MV equals liters over minute. ETV equals milliliters. PEI equals centimeters H2O. PEEP equals centimeters H2O. ESC equals ml or milliliters over centimeters H2O. PCO2 equals millimeters Hg, and PO2 equals millimeters Hg. Likewise, ESC and PO2 have somewhat improved. 100 milliliters IV fluid was administered in past 25 minutes, 15 minutes after last measurements. We're at the top of page 455 for those reading along and in the playlist on the replays. We're coming up into the next book soon, guys. I would love input. Any books that you would like to see me read on this channel. This is the time to start pondering. We're getting close to the end. Look how much is left. This is what's left. And a lot of that is bibliography. So, all right. "100 milliliters IV fluid was administered in the past 25 minutes, 15 minutes later after last measurements. BP 110 over 70. P 110. I 40. PEEP 15. ESC 36. 2 29. PO2 90. FiO2 P.60. Ventilator rate was decreased to 4 per minute. 10 minutes later, BP 120 over 80, P 110, RR 18, VT 250, MV 4.5, ETV 900, rate 4, MV 3.6, PEI 40, PEEP 15, ESC 36, pH 7.42, PCO2 33, PO2 110, FiO2 0.60. Spontaneous respirations were without apparent distress. FiO2 was decreased to 0.50 15 minutes later. BP 120 over 80, P 110, RR 18, VT 250, MV 4.5, ETV 900, rate 4, MV 3.6, PEI 40, PEEP 15, ESC 36, pH 7.42, PCO2 33, PO2 64, FiO2 0.50. Urine output was 60 milliliters in past hour. 150 milliliters IV fluid administered. PEEP increased to 20 centimeters H2O. 15 minutes later, BP 120 over 80, P 110, RR 18, VT 250, MV 4.5, ETV 900, rate 4, MV 3.6, PEI 45, PEEP 20, ESC 36, pH 7.40, PCO2 35, PO2 95, FiO2 0.50. FiO2 was decreased to 0.40 10 minutes later. BP 120 over 80, P 110, RR 18, VT 250, MV 4.5, ETV 900, rate 4, MV 3.6, PEI 45, PEEP 20, ESC 36, pH 7.41, PCO2 34, PO2 68, and FiO2 0.40. Note that within 2 hours of initiation of PEEP therapy, the clinical goals were reached. 1. Circulation and perfusion status adequate and stable. 2. Adequate arterial oxygenation at FiO2 0.40. 3. Positive pressure ventilation minimized. PEEP therapy with pulmonary artery catheter. Case study, IMV and PEEP. A 62-year-old man sustained severe upper gastrointestinal bleeding for 36 hours with significant periods of hypotension. He was taken to the operating room where a gastric ulcer was found and the appropriate surgical procedure accomplished. For 24 hours post-operatively, he was on IMV of 4 per minute. Atypical ARDS developed on the first postoperative day, and prior to PEEP therapy, a Swan-Ganz catheter and arterial catheter were placed. The patient was warm and dry with adequate urine output. MAP 60, P 120, RR 45, VT 150, MV 6.75, ETV 1100, rate 4, MV 4.4, PEI 55, PEEP 0, ESC 20, pH 7.44, PCO2 30, PO2 40, FiO2 0.70, PVO2 30, AVO2 3.3, PWP 15, C.0 or CO 5.0, QS over QT 42. PEEP of 5 centimeters H2O produced no change over 15 minutes, and PEEP was increased to 10 centimeters H2O 10 minutes later. MAP 50, P 130, RR 45, VT 150, MV 6.75, ETV 1100, rate 4, MV 4.4, PEI 63, PEEP 10, ESC 21, pH 7.40, C or PCO2 34, PO2 48, FiO2 0.70, PVO2 31, AVO2 4.3, PWP 13, CO 4.4, QS over QT 43. All right, so MAP is mean arterial pressure equals millimeters Hg. P equals per minute. RR equals per minute. VT equals milliliters, ml. MV equals liters over minute. ETV equals milliliters. And PEI equals centimeters H2O. PEEP equals centimeters H2O. ESC equals milliliters over centimeters H2O. PCO2 equals millimeters Hg. PO2 equals millimeters Hg. PVO2 equals millimeters Hg. AVO2 equals volume percentage. PWP equals millimeters Hg. CO equals liters over minute. QS over QT equals percentage. Note that the PEEP was resulted in decreased cardiac output, increased AVO2 difference, and slight decrease in PWP. A fluid challenge was carried out, see Chapter 27, with 200 milliliters of crystalloid administered over 10 minutes and then repeated over the following 10 minutes. 15 minutes later, MAP 70, P 110, RR 40, VT 200, MV 8, ETV 1100, rate 4, MV 4.4, PEI 58, PEEP 10, ESC 23, pH 7.42, PCO2 31, PO2 65, FiO2 0.70, PVO2 35, AVO2 3.1, PWP 19, CO 6.1, QS over QT 35. PEEP was increased to 15 centimeters H2O and another 100 milliliters IV fluid administered 15 minutes later. This is good, right? I know. Woo! We have the ability to do it. Understand it. And that's why I'm giving time between the readings as well, so that you have time to understand it and assimilate that information into you to recognize and be able to see. You know, that's what we do. What do I need to do, people? That's how we keep the flow going, right? All right. Yeah. Look at where your abundance administered. 15 minutes later, MAP 75, P 105, RR 30, VT 250, MV 7.5, ETV 1100, rate 4, MV 4.4, PEI 51, PEEP 15, ESC 31, pH 7.42, PCO2 33, PO2 165, FiO2 0.70, PVO2 44, AVO2 3.4, PWP 20, CO is 6.2, QS over QT 26. The FiO2 was incrementally decreased to 0.40 with a resultant of PaO2 of 65 millimeters Hg. I love it. I love it. All right. Middle of page 457. Summary of oxygenation support. Peace, highest heart, love. Thank you so much for being here, reading books with us. And the peaceful part of YouTube where we read books and learn from masters. A master fitness trainer, Uriel Riley. Highest heart, love, and honor. And welcome to this peaceful part of YouTube. We're almost finishing this book. We're in the 30th chapter. There's only 4 more chapters. So here we go. Page 457 in the middle for the replays and playlists. Summary of oxygenation support. The support of oxygenation in ARDS primarily involves the application of PEEP therapy. Of course, appropriate cardiovascular support is essential, and positive pressure ventilation should be applied to the minimal degree necessary for homeostasis. There are numerous methods for approaching such clinical care, and ours is suggested only as a guideline. However, whatever the methodology and the principles and rationale presented in this chapter must apply. In our experience, 1. Most patients with ARDS who do not have concomitant CNS disease do best with either IMV or CPAP. 2. Over 90% of ARDS patients adequately respond to between 10 and over 90% and 30 centimeters of PEEP. 3. The survival rate is dismal for patients requiring above 30 centimeters H2O PEEP, and 4. Less than 10 centimeters H2O PEEP seldom produces significant responses in adults. Prophylactic antibiotics in ARDS. Significant threats to the survival of the ARDS patient are pulmonary infection and generalized sepsis. Many ARDS patients are excellent hosts for bacterial superinfection because of their diminished immunologic status and the numerous iatrogenic pathways for bacterial contamination. In addition to possible contamination of urine, intravenous, arterial, and central venous catheters, the placement of an intratracheal tube and respiratory apparatus leads to certain contamination of the tracheobronchial tree. Although careful and constant evaluation must be maintained for pulmonary bacterial superinfection, there is no indication for giving prophylactic antibiotics. No convincing evidence exists that prophylactic antibiotics decrease the incidence of pulmonary bacterial superinfection in these patients, but it appears that they most probably increase the incidence of gram-negative superinfection. steroid therapy in ARDS. In ARDS. Appropriate administration of steroid compounds may be of benefit in reversing ARDS of certain etiologies. It has been postulated that there is a decrease in the tendency for white blood cells to adhere to pulmonary capillary walls following hemorrhagic shock when the patient is preloaded with methylprednisolone, methylprednisolone, sodium succinate or solute medrol. Also, steroid therapy may enhance surfactant production by stabilizing the cell wall membranes of alveolar type 2 cells. There has also been reasonable clinical evidence, especially in fat embolization, to show that steroid therapy does play a role in interfering with the pathophysiologic process of ARDS. Obviously, the numerous causes of ARDS explain differences in the clinical disease process, and this may well account for the variability of reaction to various steroid regimens. Steroid therapy in large doses for short periods of time is well accepted in critical care medicine and immunology. There is little evidence that large doses of steroid compounds administered over short periods, pulse doses of less than 48 hours, are significant in depressing the body defense mechanisms or producing electrolyte imbalance. The classic side effects of steroid therapy are based on long term administration rather than on short term pulse doses. The use of steroid therapy in ARDS is controversial. We believe it is reasonable to consider early intervention with large doses of methylprednisolone sodium succinate, 15 milligrams kg, 4 to 6 times a day for a period of 24 to 72 hours. Although convincing documentation is still lacking concerning the clinical value of this course, there seems to be reasonable evidence that it may, in fact, play a role without significant harm to the patient. Peace. I will put the vocabulary in the description when it's finished uploaded and complete. Thank you so much. Happy Saturday. Highest heart love. Thank you so much for the likes and subs. We're pushing towards 600 on this part of YouTube where it's peaceful and we read books and learn. So highest heart love. Here we go. Top of page 459. We did it. Diuretic therapy in ARDS. The increased interstitial water of ARDS is not significantly diminished by diuresis. However, many patients may benefit from diuretics for non-pulmonary reasons. Although intravascular volume must be maintained, fluid overload is detrimental and should be meticulously avoided. Ding! We completed chapter 30. Woo! We are on fire. We are the champions of reading. No doubt about it on YouTube. Highest heart love when we reconvene with clinical application of respiratory care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. We will be into the 31st chapter. Highest heart, love, and honor to all our friends and family. shaking it up on YouTube, reading books. Feel the power. We completed another chapter in less than an hour. Thank you so much. Oh man, love to all the book readers, all our friends and family, right? Thank you so much for being here and reading with us, all book lovers community. We're doing it, showing the way, leading. Right? Master thyself. Thou shalt know the whole world. Thank you for reading anatomy books with us and biology. Love to all our friends and family, all the birthdays. Teresa, highest heart love, my family. I love you so much, Ressa. Yeah, look how far you came. And now you're a mother, right? Cheers to you. Highest heart love. I have so many cousins. I have over 100, 200 cousins. And yeah, that's second cousins going into, but over first cousins, I have over 50. So yeah, I have a big family to hug on and love. And, you know, that's why we honor ourselves, you know, so we don't dishonor our families and friends and ourselves, right? Our spirit energy keeps rising. And that's why uplifting the people, being encouraging and loving to one another, that uplifts the people, right? Fire burns up. We light that flame here, reading books live from the light. So let's have a drink of love water. I love you so much. Sing it to you. Love you. Thank you so much. Congratulations, Marquise, clearing another hurdle. Did it. I love you. I love you. I love you. I love you. Gratitude at highest heart love. I want you to have a wonderful evening. We are going to the light green cloud tonight. Some healing and restoration. We'll be going over different healing techniques and using energy, light, colors. It's always great using in therapy, color therapy. One of my favorites. So, live from the light. We did it again. Thank you so much for being here. I love you. I love you. You know, because I love myself. From the light. We did it again. Going into chapter 31. All right. I'll see you soon.